Welcome to This Week in South Carolina. I'm Gavin Jackson. Opioid-related deaths continue to rise in the state. From 2014 to 2017, South Carolina saw a 47% increase in opioid-related deaths because of the rising problem. A statewide opioid response team was formed in 2017. Through this group, officials hope to see a decline in this deadly addiction. South Carolina, like other states, continues to see its opioid overdose death rate climb due to prescription drugs, heroin, and especially the synthetic opiate fentanyl. 748 people died from opioid-related drug overdoses in 2017 alone. The life-saving nasal spray Naloxone serves as a last resort on the front lines of this epidemic for those who still use and overdose. This video from a Florida sheriff's office shows a scene similar to some 7,200 cases first responders in South Carolina faced in 2017, a 92% increase from the previous year. The drug reverses the debilitating effects of opioids in users within moments if it's not too late. Efforts to intercede in this problem continue to command the state's attention, including a state of emergency issued in late 2017 by Governor Henry McMaster. The order created an opioid emergency response team headed by addiction specialists and law enforcement.
We have concluded that it is time to take a dramatic step to engage all the resources that the state has, including that of public awareness and public opinion, to address this crisis. So I have today declared a statewide public health emergency for the state of South Carolina, effective immediately and remaining in effect until revocation by a subsequent executive order.
Joining us to discuss the ongoing opioid epidemic is the director of the South Carolina Department of Alcohol and Other Drug Abuse Services, Sara Goldsby. Sara, thanks for joining us.
Thanks for having me.
So Sara, we've been talking about this ongoing epidemic, and before we get into all the trends and all the data that we have, can you just tell us maybe some things that folks watching at home can maybe do to help prevent or help others going through this problem right now?
Absolutely. This crisis started with prescription drugs, and I think one of the first things people can do is get rid of the unused medications in their homes. We've really pushed that with our public education campaign, but clean out your medicine cabinet. Find a location, a permanent drop box near you on justplainkillers.org, and get rid of those prescription drugs. We know that a lot of adolescents are misusing those prescription drugs in the home first. Their perception is that they're safe because they're given by our medical professionals, and really there's a high risk there. So lock up anything that you need, get rid of the things that you don't need safely. Second, understand the signs and symptoms of overdose and know how to reverse overdose. A lot of folks are at risk. Our seniors who may mistake their pain pill for their hypertension medication are at risk, as well as our adolescents who think of misusing a substance even once. And so know how to access naloxone, know what overdose looks like and how to reverse it. And then know where to support someone who needs help. You know, there are places of recovery support and treatment support all over the state. And so our state website, the Just Plain Killers site, offers those locations. Pick up the phone and call for help when you know someone needs it. Some
great advice to start off with, but tell us a little bit about what the current state of this opioid epidemic is in South Carolina. Are rates rising? Are deaths increasing? What are we looking at right now in South Carolina?
Unfortunately, the mortality is continuing to increase related to opioid overdose and all drug overdose deaths. In 2017, our latest mortality data shows we lost 748 South Carolinians to this crisis. And, you know, those are our friends and neighbors and family members, people we know, you know, not just numbers, but that number is up from 616 in 2016. And so the trend is definitely going in the wrong direction.
And what do you see driving that? Is there, this has been a problem for years, but why are those numbers still increasing?
It's really related to the illicit acetyl fentanyl that's coming into the state, coming into the United States from out of the country. The access to that really potent non-medical fentanyl that is extremely deadly if used even once. And so we know it's being mixed with other illicit substances, cocaine, marijuana, and coming in. And so as folks have less access to the prescription drugs that they may have been hooked on or dependent on, they're accessing these illicit substances that are extremely deadly.
And the current, we'll talk more about fentanyl and OxyContin, obviously the big drivers, and of course heroin. But the current status of the governor's opioid emergency response plan and team, which was created last June, and you co-chair that team along with SLED Chief Mark Keel. What's the status of that? We're under a state of emergency in South Carolina for this opioid problem. What's the current update that you guys have maybe about that team and where we're going with progress, perhaps?
Yeah, so there's about 25 or more organizations and entities, both public and private. It's kind of an all-hands-on-deck team working on 4 focus areas and many, many objectives. So we published a progress report in January, really letting everybody know, the governor and the legislature know the progress on these objectives that we put together, those 4 focus areas: communication and education, prevention and response, treatment and recovery, and then the law enforcement, the coordinated law enforcement efforts. Right now, the plan is being revised. We're pulling everybody together to take a look at what we've accomplished and what is on the horizon. What are the objectives that we need to add to the plan and be working on? So the effort is ongoing across agencies and organizations every day.
And anything you guys can point to, any early successes at this point that we can point to?
You know, I've got to hand it to law enforcement. They've really pulled together to find solutions to eliminating the unused prescription drugs in our state that had really been stockpiled by law enforcement. We needed a solution to get those incinerated and disposed of safely, and they worked together to collect those and get them out of state safely. So it's been a tremendous effort there.
And in terms of, we can talk about legislation a little bit, but in terms of what we're doing in South Carolina, are we on track with what other states are doing in terms of responding to this epidemic, or how are we handling it so far?
You know, every time I think we're behind, I talk to other states and I find that we're kind of ahead. I would say our efforts are probably out there in front of other states in a number of ways. We still have a ways to go on some things, but all in all, I feel like we've been very coordinated, and that's the benefit of being a small state and being so connected. Mm-hmm. Everybody works well together here in South Carolina.
And I think maybe one of those factors, too, is that I asked you earlier about how come we weren't as badly affected as other states that have been really ravaged by this epidemic. What can we point to in terms of, you know, while we do have 748 overdose deaths from opioids specifically, 1,000 drug deaths overall in 2017 as well, what can we point to say that, hey, we're helping mitigate this situation before it became as big of a crisis as it was in other states? Yeah,
I mean, those numbers that you point to, when you apply those to rates, South Carolina is really on the median of severity among other states. And I would really give a lot of credit to our Bureau of Drug Control, operated by DHEC. You know, early on, even in the mid-2000s, they were doing an excellent job imposing regulation and making sure that we weren't allowing those pill mills to pop up in South Carolina the way they popped up in Florida and in New Mexico and other states, dispensing immense amounts of opiates to the citizens. We didn't have that here.
Mm-hmm. And I read a staggering statistic that I'm going to read about 70,000 Americans died from drugs, of 47,600 just from opioids in 2017, and that's more than all the Americans who died in the Vietnam War. When you see a number like that, and I know, you know, South Carolina, we said 1,000 in 2017 from drugs, period. How hard is it to keep fighting this battle? Your agency is a small agency. You guys do work with other state agencies to fight this battle, but how difficult is it to, day in and day out, kind of go up against these numbers?
It's really hard, and it's really heavy. You know, because we have so many families who are hurting because of this. Those numbers are people. Mm-hmm. And there's not a week that goes by that I'm not, you know, hugging a mother who's lost her child, or consoling a dad or a husband who's lost a family member. And so our agency hears the voices of those people who have really been impacted. And so there's a heaviness with that, a sense of urgency with that. And we take it very seriously. The responsibility to address this issue is urgent.
And looking kind of back at the history of all this, we were talking about how OxyContin really kind of was the big driver, a lot of this in 1996 when it came on the scene from Purdue Pharmaceuticals. And then, you know, OxyContin was 2 times stronger than morphine. It was supposed to be like more of a long-term, last like 12 hours or so. Wasn't supposed to be as addictive. That's how it was aggressively marketed towards doctors. We're finding out through documents and court documents that this was not the case. Purdue's under a lawsuit from multiple states, including South Carolina. Walk us through how we kind of got to this situation, starting with pills and to the current state.
Yeah, it was kind of a perfect storm there in the late 90s. Purdue marketed OxyContin, as you said, to be non-addictive, but we knew an opiate's an opiate. This isn't even our first opiate crisis, to be honest. But they told doctors and other prescribers that it was safe to treat pain. And at the same time, you know, our Centers for Medicare and Medicaid Services were grading hospitals and prescribers, excuse me, on treating patients' pain, addressing patients' pain. And reimbursement of medical services was really driven by patient satisfaction scores with their perception of pain.
So if I'm going to pain and I'm not getting treated for pain, then I'm going to give them a low score, so they're going to get lower reimbursement. So.
Absolutely. So these things happen simultaneously, and our prescribers were under a lot of pressure to address patients' pain. This was marketed as an easy solution, a quick fix. It did alleviate the perception of pain in patients, and that's really how we got into this crisis. It's been really unfortunate that our prescribers haven't been supported with better ways to address pain, because pain is real. We really have people who are hurting, and our healthcare professionals are there to alleviate that suffering. And so at this point, it's really about supporting them and resetting expectations with patients and patients' perception of pain, and helping address it in a more functionality-based approach. Knowing that pain is real and there is going to be pain. We can't expect everybody to have zero perception of it.
And kind of on the flip side, we can look at more long-term ramifications of this crisis in a moment, but just along that vein, I was talking to a pharmacist recently about this, and he said that, you know, not everyone who actually is experiencing pain, say like a cancer patient who has clear documented pain, is now getting as much medication as they should, because of insurance companies now kind of cutting back on that as well. So is that kind of one just small ramification of how now it's maybe affecting the people that actually need these medications too?
You know, we hear those things about insurance companies all the time, and I think insurance companies are really charged with a number of things related to patient safety and risk of prescriptions. What we know is policy that has passed was really focused on acute and post-operative pain. We know that there's a need with chronic pain patients to address that issue. And so none of the conversations, policy that we've put in place have really been about limiting access to those folks who really need it long term. It's really about the acute and post-operative pain that we wanted restrictions.
Because that was a piece of legislation that we also recently passed too,
yes.
The post-operative.
I think it'll make a big impact, you know, limiting those prescriptions to 7 days, acute and post-operative pain. So we're not giving somebody 30 days of a prescription opiate after they've had a tooth extracted, for example. Which
will then, you know, they'll use it for 2 weeks and then leave the rest of the medication in the medicine cabinet, then it could lead to, you know, exposure for someone else.
Yeah, absolutely.
Lead to addiction then. So then we went from, you know, the prescription pills driving this crisis to then, you know, them cracking down on OxyContin. You know, they made it so you couldn't crush it up and you couldn't dilute it, you couldn't snort it. So then that led to an increase of heroin, understandably. So then that was the second wave. So what's the status of that in South Carolina, heroin use and abuse in South Carolina?
Yeah, so, you know, the black market of illicit substances pays close attention to the habits of Americans. It's very economic. And as we've reduced the access to those prescription drugs that are misused and abused, the outsiders, folks outside of our country, have really stockpiled illicit substances to fill the gap. And they're coming into the United States, like I mentioned, cocaine, methamphetamine, and then the fentanyl that's accessible now to those folks who are needing it, you know, and it's not that folks are after it to get a high necessarily anymore. They're after it because their brain is dependent on it, and they're just trying to feel normal and stable and not feel withdrawal symptoms. And so the demand is high, and that's what's accessible.
And then along with that, you know, injecting heroin comes the rise in infectious diseases. I just saw something from the National Institutes of Health this week that said, you know, hepatitis C and increasing rates of HIV are now becoming a converging public health crisis. So you have these infectious diseases increasing, you still have opioid-related deaths increasing. what are going to be the ramifications of that, and what's it look like in South Carolina when it comes to Hep C and HIV rates?
Yeah, I mean, it's really a syndemic, right? These things are completely intertwined, the infectious disease and the substance use. And so I always say, you know, we're kind of in an addiction crisis right now, but we're going to be in a Hep C crisis in about 10 years. The risk of infectious disease is real. Our folks who are misusing substances are contracting these infectious diseases, and so we've got to be testing, we've got to be coordinating patients to care to address those early. The earlier you address hepatitis, you know, the less cost is associated with that health care.
Mm-hmm. I mean, those rates jumped 92% from 2014 to 2017 for hepatitis C. Looks like HIV numbers kind of remain steady, but 6,730 new cases in 2017 alone.
Yeah, we're pursuing federal funding right now, actually, to get more testing and coordinated care in the places where folks with addiction show up for treatment. Mm-hmm. We want everybody who comes in with any substance use disorder to be tested, see if they have that infectious disease, and coordinated to infectious disease doctors.
And then the third wave of all this was the fentanyl crisis. That became more and more I guess, obvious in the end of 2013 when it kind of came on the scene more. It's 50 to 100 times more powerful than morphine. Just a little bit of it can really kill somebody. How big of a problem is that in South Carolina, and is that the primary driver of deaths when we look at these overdoses?
In the last few years, it is the reason our rates of death have gone up. It's the reason the rates of our overdose reversal have gone up. And so we have to recognize everybody who is at risk. We have to know that every death related to overdose is completely preventable. And that's why we're working so hard to get Naloxone available and accessible to anybody who is at risk of overdose. And we have to think outside of who we would normally perceive as at risk. You know, it's not this picture of a person in an alley shooting up heroin. It's our college students who are thinking of using a substance even once. It's our...
so like taking one pill someone gave you thinking it's one thing.
Absolutely.
Turns out to be a complete different thing.
Right. So recognizing who's at risk and making that Naloxone available, because every single overdose death is absolutely preventable.
And we can talk about Naloxone in a moment, but you mentioned federal funding. I know the SCDAODAS just got a pretty big grant from the federal government. How's that being used? What's the status of that, and is it being effective at this point?
Yeah, Congress has been very generous in the last few years, giving sort of one-time appropriations to states. So South Carolina was eligible to receive the state opioid response grant. It was about $14 million a year for 2 years. That funding ends September 2020. With that funding, we've been able to, you know, do so much more statewide in terms of prevention, intervention, treatment, and recovery. Really building the capacity for treatment and recovery, both getting access for folks to get treatment, supporting recovery community organizations, supporting the Department of Corrections and our inmates who have substance use disorder behind the walls, and supporting them especially when they're reentering. Very vulnerable folks leaving prison, they're at high risk of returning to use. And so really supporting them in that transition. Getting the Naloxone available everywhere, as I said, and then a lot of environmental prevention strategies, supporting communities to put in place education, evidence-based prevention work.
And you mentioned inmates returning, and then also, I mean, you have a lower tolerance to these drugs too, so you come out, you think you can just do one hit of something, and all of a sudden, it's another statistic, apparently.
Right. So for that population, and then for anybody who has opioid use disorder, we say detox or withdrawal management is not treatment. In fact, it's fairly risky. We withdrawal or detox completely somebody from opioids, their return to use risk is very high. And so their overdose risk becomes that much higher. So we really support stabilization with medication so that folks can be stable on a medicine and receive that psychobehavioral treatment long-term as a chronic disease management.
And I want to talk about just kind of where things stand with, you know, moving forward in terms of are there potentials for any more federal funding to address this issue? Do we need more money? How much more can you throw at this problem, and does that fix it? I mean, do we need to start focusing on treatment more, or what's the next I guess, big need for SCDAODAS when it comes to this problem?
So the issue is complex, and so the response has to be is obviously equally complex or broadly based. Treatment is essential. We look at that federal funding with gratitude. We are so grateful. It is a blessing. But I think all states are really saying at this time, we need some long-term guarantee with the federal support. With each wave of funding we've received from Congress, there's come a fiscal cliff. And so this notion that if there are not more appropriations, that support will be gone. And I think the Substance Abuse Prevention and Treatment Block Grant, you know, the block grant that the state has received for many, many years to support prevention and treatment services of addiction, is one way that we can really stabilize the funding, give South Carolina and all other states the flexibility we need to address addiction and the needs in our own way. And so we're really hopeful that Congress and our federal leaders recognize that need and kind of give us some long-term stable funding with the flexibility.
And just kind of before we move on, really quick, does this move funding away from other needed drug abuse services? We talk about alcohol. You know, alcoholism is also a huge problem in the country. People die from it, and we can't really quantify it necessarily as much as we can, you know, how many deaths attributed to opioids, because so many factors lead to death when it comes to from alcohol. But is money moving from these other needed addictions, or is it because it is a crisis that's kind of all hands on deck?
Yeah, I would say money isn't necessarily being moved away from issues with other substances, but we're really limited with this funding to only address opioid use disorder. And I know that our federal leaders recognize, and everybody is saying right now, this is more than just an opioid crisis, it's an addiction crisis, and it's evolving. And so we see cocaine, methamphetamine on the rise. We still have the greatest issue with alcohol, even marijuana use. We have more folks treated for marijuana use disorder in the state than we have treated for opioid use disorder. And so we need the flexibility with the funding to address addiction. Addiction is a disease. Opioid use disorder is serious. People are dying. We've got to address that. But ultimately, this thing is going to change and evolve.
And you were talking about Naloxone, which is that opioid reversing antidote, that drug that can help essentially bring people back from overdosing, that nasal spray. In 2017, there's about 7,200 administrations of that drug in South Carolina alone. That was a 90% jump from the previous year. What do those stats mean to you, and is this becoming a real last-minute, safety net for these people at this point?
So the numbers are growing because our emergency responders are addressing more overdose incidents. I would say it's a good thing. Every single time someone overdoses, they must have the opportunity to live, to survive, to achieve recovery, as many times as it takes. And so it's scary. We don't want people overdosing, but it's a good thing that those reversals are occurring and that Naloxone is saving their lives. I would just say, for as long as it takes, we've got to have that drug available to keep people breathing and get people to the other side.
And the availability of that drug became more prevalent because a huge slate of legislation moved through the State House recently. Can you elaborate on that and maybe what we can expect this year, perhaps?
So our legislators have been wonderful, and the governor has been wonderful to sign into law a few acts that have helped Naloxone become more available. The Overdose Prevention Act, Representative Chip Huggins sponsored that bill. We've amended it, and now we have community distribution of Naloxone. And so working with our boards of medical examiners and pharmacy and nursing, SCDAODAS is now sort of authorized to authorize community distributors. So organizations and entities with good intent of getting Naloxone more available locally. We're allowing them to distribute Naloxone with a standing order prescription to those individuals without individual prescription. People can access it sort of over the counter, but from multiple locations.
And moving forward too, I know we have about 3 minutes left, so there's a lot more to cover still. Yeah. But looking at treatment, medically assisted treatment, is access to that becoming greater in South Carolina? More people seeking that treatment? Is that really the only way to really kind of help address this problem still? I mean, the only way out in a sense?
Yes. So the capacity to address this disease medically is increasing. We've worked really hard to do that. But there is still some need. And what we really need is we need all of our healthcare providers addressing addiction as a medical, treatable, long-term chronic disease. We need all prescribers to be able to screen and treat addiction medically in coordination with behavioral health specialists. And there's a lot of work to do there. I think there's still a tremendous amount of stigma related to addiction that's going to keep us in this crisis. We've got to break down that stigma. And there's a stigma around treating this addiction medically, which we know is essential to keep people alive. So we have a long way to go, but we've made tremendous progress, and treatment is more accessible now than it has ever been before.
And one of those big big areas too is Medicaid. Being able to get people, Medicaid enrollees in South Carolina, have access now, as of January, to these treatment services, and they're fully funded, is my understanding?
That's right. Medicaid's done a great work. Josh Baker and his team have done a number of things to really push the managed care organizations to make this treatment more accessible for their beneficiaries. It's been a blessing, and I know they're still working hard with some policy to make this coverage more available.
And I think DHHS has medical assisted treatment pilot program going on in a couple ERs on the coast.
Yeah.
Can you elaborate on those? Are those going to be hopefully more widespread? I know we were just talking about medically assisted treatment, but what do those look like, and are those going to be going forward?
This is really important work, because when folks overdose and they're taken to the emergency room, this is an opportunity for them to get stabilized and coordinated to outpatient services. So we started with a couple hospitals. Our legislature, DHHS, are helping us scale that up to more and more hospitals. So as folks come in with an overdose, they can be stabilized with medication and really handed off warmly to outpatient services for long-term outpatient treatment.
So that's something we hope to see becoming more prevalent statewide in the future?
Absolutely.
I think that was some really great information. I just want to end with a sobering fact that Harvard medical professor John Kelly estimates it takes 8 years and 5 treatment attempts to achieve a single year of drug abstinence. Some difficult numbers to digest, but it just goes to show that it is possible to achieve people moving forward and surviving this epidemic.
We have more than 300,000 South Carolinians living in full recovery right now, and more every day. So recovery is possible. It's about getting folks to recovery and supporting them in long-term recovery.
Wonderful. Thanks to Sara Goldsby with SCDAODAS for joining us. And also check out the South Carolina Lead, a political podcast that can be found on your podcast app on any mobile device. Each week I recap the weekly political news with the reporters who cover it. From the Kennedy Greenhouse studio on the campus of the University of South Carolina, I'm Gavin Jackson.